Welcome back to the deep dive. Today, we are not just scrubbing in, we are doing a deep dive into the blueprint of knee stability, specifically tackling the notorious medial side.
Oh, it's notorious for a reason.
It is. Grab your anatomical text because we are doing a rapid-fire, highly focused review, a pre-ops simulation, if you will, of a foundational area where missing one small millimeter of anatomy or failing to appreciate a biomechanical nuance can absolutely torpedo your outcome.
It's the ultimate surgical high-wire act, isn't it? The medial knee is a place where treatment requires, more nuance than almost anywhere else.
I agree.
If you look at our source material, we're synthesizing foundational knowledge, the Warren and Marshall classics, with the precise surgical mapping provided by LaPrade and his group. Our mission today is to synthesize the literature on medial ligamentous injuries, or MLI, focusing on the MCL and the incredibly complex posteromedial corner, or PMC.
We're treating this deep dive like prepping for a high-stakes combined knee case. This isn't just theory. This is the difference between a stable knee and a long-term failure requiring revision.
Right.
We need to know the structures, the failure modes, the intricate load-sharing properties, and the precise surgical algorithms cold. Because frankly, if you miss a grade 3 valgus instability or tension your graft incorrectly, your beautifully reconstructed ACL is going to take a permanent beating.
Precisely. We often hear the ACL described as the primary stabilizer, but the MCL-PMC complex is the essential static stabilizer to valgus stress and external rotation. It's the wall that keeps the car from skidding off the road. When it fails, the kinematic changes are immediate and profound.
Yeah.
Understanding this complex is the non-negotiable prerequisite for sound, reproducible results in knee surgery.
All right, let's start with the absolute foundation.
Yeah.
The anatomy.
Okay. We are channeling Warren and Marshall, whose 1979 work established the spatial concept that, it revolutionized how we think about medial approaches. They provided the classic description of the medial knee divided into 3 distinct layers.
And if you can't visualize this layering, you can't operate safely or effectively.
You can't. We visualize it like an onion, or as you suggested, a high-tech layered security system for the joint.
A security system where if you cut layer 2 without respecting layer 1, you end up with a mess of tendons. And if you cut layer 3 too deep, you're suddenly intra-articular where you don't want to be.
Exactly. This layering is not just academic. It dictates every single surgical approach. We start externally and move deep, defining our operative corridor.
Okay, so layer 1, the outer envelope, this is your initial perimeter fence.
Mm-hmm.
It consists primarily of the crural fascia of the knee, spanning from the patella anteriorly all the way back to the popliteal fossa posteriorly. The structure often encountered within this layer, which acts almost like a separate landmark, is the sartorius fascia.
Right, and it blends beautifully into the crural fascia as it attaches to the tibia. It's thin, translucent, and, easily passed through.
But layer 1 serves a critical purpose.
It does. It hides the key interlayer landmark. The gracilis and semitendinosus tendons, collectively known as the pes tendons, reside right between layer 1 and layer 2. When you incise that crural fascia longitudinally, those tendons pop right into view. They are your guide. You retract them anteriorly or posteriorly to expose the SMCL without disturbing the overlying fascia or the deeper structures.
So that landmark is indispensable.
Absolutely.
And once those tendons are mobilized and retracted, we're looking right at layer 2, the main restraint.
Yep. This is the superficial medial collateral ligament, or SMCL. It is the primary passive restraint we spoke of. In an acute setting, or one without dense scar tissue, it should be easily identifiable as the thick, substantial band of tissue running obliquely.
And this is where precision becomes paramount, especially if we were attempting an anatomic reconstruction.
It is. We have to move past simply finding the ligament and reference the cartography provided by LaPrade et al. Their quantitative work on the attachment points defines surgical success.
These are the measurements that must be committed to memory. For the femoral attachment, the SMCL attaches an average of 3.2 millimeters proximal and 4.8 millimeters posterior to the medial epicondyle.
Just think about that. We are talking about precision of placement within a 5-millimeter zone.
Which is why we rely on specific fluoroscopic views or instrumentation to hit that mark. If you are off, even by a centimeter, you change the kinematics profoundly.
Oh, completely. You either over-constrain the knee inflection or leave it dangerously loose in extension.
That's right. Getting the trajectory and the starting point wrong changes the isometricity.
Yeah.
If you place the femoral attachment too far anteriorly, you become taut in flexion, leading to stiffness.
And if you place it too far posteriorly, you will lose stability in full extension. The numbers 3.2 and 4.8 are the gold standard coordinates for the femoral socket.
Now, let's consider the tibial attachment of the SMCL. It's slightly more complex because it has two divisions.
It does, yeah. The proximal division attaches only to the surrounding soft tissue, primarily fascia and the pes layer. The distal division, however, has a direct, firm insertion into the bone of the posteromedial tibia. This distal attachment is the target for the lower limb of the reconstruction, situated about 4 to 6 centimeters distal to the joint line.
And we have to remember that SMCL fibers are deep to the pes attachments.
Oh.
Moving inward, layer 3 is a deep connections and the corner complex. This is the inner sanctum, the knee joint capsule itself, which becomes incredibly thick as we move posterior.
Right, and deep to the SMCL is the deep MCL, the DMCL.
And we must emphasize its unique anatomy as defined by Laprade. It's a distinct capsular thickening that has meniscofemoral and meniscotibial attachments, but it has no attachment to the overlying SMCL.
None. They slide over each other. And that lack of direct attachment is why the SMCL is considered extra-articular and why it heals so well, while the DMCL is intra-articular and doesn't. They are separate anatomical sheets.
And layer 3 is also home to the complexity of the posteromedial corner, the PMC. Nomenclature here used to be a mess.
It's a total mess. But thanks to Robinson, Laprade, and others, we now define the posterior oblique ligament, or POL, as a key recognizable thickening of that posterior medial capsule.
And the POL is not a simple ribbon, is it?
Not at all. It's a functional tri-layered structure itself. The superficial arm, the central arm, and the capsular arm. This is a critical distinction for surgical repair.
Can we elaborate on those three arms? Why is the central arm the focus?
Sure. So the capsular arm blends into the posterior capsule and is the weakest. The superficial arm runs more vertically, often blending with the semimembranosus sheath. But the central arm is recognized as the most robust structure, inserting adjacent to the semimembranosus tendon.
Ah.
When we talk about reconstructing or repairing the PMC due to significant rotatory instability, the central arm is the primary target for anchoring the tissue or placing the graft to restore that posterior tautness.
So if you only focus on the superficial arm, you miss the major check rein against posterior external rotation.
You just the whole point, yeah.
So the complexity of the PMC is also due to the surrounding muscle attachments.
Absolutely. The PMC is structurally reinforced by the semimembranosus and its sheath through multiple attachments, the so-called semimembranosus footprint. It's an incredibly dense, layered area where the muscle fibers and the capsular ligaments merge to provide dynamic stability, particularly when moving into extension.
Okay, so let's tie the security analogy together now that we have the full picture.
Let's do it.
Layer 1 is the crural fascia, the thin wire fence. Layer 2, the SMCL, is the main security gate, the robust band that takes the primary impact.
Secured by the 3.2 and 4.8 coordinates.
Exactly. And layer 3, the DMCL and the POL, those are the internal foundation anchors, tied directly to the joint and reinforced by the heavy machinery of the semimembranosus.
That's a great way to put it.
So if an intruder gets past layer 2 and damages the central arm of the POL, you've got a massive multi-directional instability that requires heavy-duty repair.
A catastrophic breach. Which smoothly takes us to understanding what happens when stress is applied to that system.
Let's pivot to biomechanics. While we debated the names of the ligaments for decades, the biomechanical role is pretty well defined.
It is. These structures are the primary resistance to valgus force and external rotation, and the key is that they are flexion-dependent.
This concept is crucial for diagnosis. The research by Griffith et al. Show that both divisions of the SMCL serve as primary restraints to valgus load and external rotation.
Right. But the knee is a cam, not a hinge. So the degree of knee flexion dramatically influences the specific structures carrying the load.
The crucial difference between extension and flexion, identified by Robinson et al., lies in the tension profiles. Why does the tension profile change?
It's because the medial femoral condyle is not perfectly spherical. As the knee extends, the radius of curvature changes, and the origin and insertion points move relatively apart, which tensions the posterior structures.
So when you look at the SMCL, its anterior aspect remains taut throughout the entire range of motion. It's always ready to resist valgus.
Always. However, the deep structures, the PMC complex, particularly the POL, demonstrate a dramatic shift. They consistently loosen in flexion, but become taut and tighten in full extension and internal rotation.
And this is the physiological mechanism we exploit during the physical exam.
Exactly.
This distinction is why, clinically, we must check at both 30 degrees and 0 degrees, At 30 degrees of flexion, the POL is slackened, so you are primarily isolating the SMCL.
You are testing layer 2.
You're testing layer 2, so if you see instability only at 30 degrees, you have an isolated SMCL injury.
Conversely, testing at 0 degrees, or full extension, brings the entire PMC complex, the POL, into play. You are testing the combined integrity of layer 2 and the deep anchors of layer 3.
So if a joint opens at 0 degrees, you know those deep posterior anchors have failed.
You know it.
Let's nail down Griffith's findings on the primary static stabilizers, because this is where we define the function of those anatomical subdivisions we just discussed.
We must. The specific functions are, 1. The proximal division of the SMCL is the primary stabilizer to valgus stress. This is the workhorse against a direct blow to the lateral knee.
Okay.
2. The distal division of the SMCL is the primary stabilizer to external rotation, specifically at 30 degrees of flexion. It helps control tibial rotation when the knee is slightly bent.
And the SMCL as a unit.
As a whole unit, it's the primary restraint to valgus and internal rotation at all flexion angles and to external rotation at 30 degrees.
What about internal rotation stability, which is often harder to assess clinically?
That's controlled by the posterior quadrant. The POL and the distal SMCL division are the primary restraints to internal rotation at all flexion angles.
And the DMCL.
Have to acknowledge the DMCL. That deepest layer contributes significantly to flexion-dependent internal rotation stability. It's a dynamic, integrated machine where one structure compensates for the slight laxity of another based on the degree of flexion.
This brings us back to the crucial concept of load-sharing properties,
Yeah.
demonstrated so well by Widdix et al.
Widdix performed sequential cutting studies. The analogy of a suspension bridge is excellent here.
It really is.
You have multiple cables, and they all contribute. If you cut the main cable, say, the SMCL, the load doesn't just vanish. The tension instantly shifts to the deep structures, the POL and DMCL.
Right.
Widdix demonstrated that cutting one structure instantly alters the force required to open the joint, proving that they are constantly sharing the burden.
Which explains why we can often treat grade 2 injuries conservatively. The secondary stabilizers immediately take up the slack, allowing the primary structure to heal.
Exactly. But this load-sharing concept is also why combined injuries are so devastating. If the ACL is also gone, it's not just the medial side compromised.
Because the ACL normally acts as a secondary valgus stabilizer.
Right, particularly against combined valgus and internal rotation moments. If that's gone, the entire medial complex, even if surgically repaired, is under much higher residual strain. It's a system failure, not an isolated cable snap.
That inability to compensate, due to the loss of a secondary restraint, is the central reason why the treatment protocol for an isolated MCL tear is fundamentally different from a combined ACL-MCL tear.
And that takes us to how we spot that failure in the clinic.
Clinical assessment starts with the history. Isolated MCL injuries typically occur when the foot is planted, and a valgus moment is applied to a slightly flexed knee, the classic clip injury in football.
And the rotational mechanism is the red flag?
Always. Heavy rotation immediately elevates our suspicion for multi-ligament damage or a lateral side injury.
Inspection clues are simple but vital. We're looking for swelling. If you see a major hemarthrosis, a large effusion inside the joint, you must suspect intra-articular injury, an ACL, meniscal tear, osteochondral fragment.
Whereas isolated MCL tears are extra-articular.
Correct. They cause localized swelling and ecchymosis along the medial joint line, but the joint itself should be relatively dry. And, of course, always perform a comprehensive neurovascular and full ligamentous exam.
Then, the moment of truth. The valgus stress exam. We determine the grade of injury by quantifying joint line opening under stress at two specific positions, 0 degrees and 30 degrees of flexion.
And comparison to the contralateral uninjured knee is non-negotiable.
Right.
Our grading scale dictates the treatment algorithm. Grade 3 is a soft endpoint, but less than 5 millimeters of increased opening.
Grade 2.
Grade 2 is a distinct but firm endpoint, between 5 and 10 millimeters of increased opening. And grade 3 is a soft endpoint. Greater than 10 millimeters of increased opening is suggesting complete disruption.
And what separates the isolated injury from the combined injury, it's that test at 0 degrees.
Precisely. Increased laxity and full extension is the hallmark of PMC failure, meaning the posterior oblique ligament, the deep anchor, is also disrupted. This is the marker that indicates a severe multi-structure failure.
And this is Feddo's classic work.
It is. He showed an 80% incidence of combined ligament injury, most commonly ACL, when a grade 3rd MCL tear demonstrated laxity at 0 degrees. So if the knee opens up in full extension, you are highly likely dealing with that 80%. You need to assume an associated ACL tear until proven otherwise.
So the grading scale itself is more of a guide to medial integrity, but the location of the instability 0 degrees versus 30 is the guide to associated ligamentous injury.
Exactly. Now let's talk rotational instability. We need to look for increased internal rotation. This strongly suggests failure of the PMC complex, the POL, and distal SMCL.
And the distinction between medial and lateral rotational issues is crucial here. While increased external rotation is often associated with a posterolateral corner or PCL injury, Griffith reminded us that the SMCL also restrains ER. How do we differentiate that clinically?
We use the physical inspection of the tibia during the external rotation test. If the medial structures are injured, the anteromedial tibia rotates anteriorly relative to the femur. If the lateral structures, the PLC, are injured, the interolateral tibia rotates anteriorly. That visual cue, watching where the rotational instability is occurring, dictates whether you are dealing with a medial or a lateral soft tissue problem.
Moving to imaging. Radiographs are standard looking for avulsion fractures, which often occur at the femoral insertion or joint malalignment.
And in chronic cases, you need long cassette standing views to assess alignment and the extent of valgus thrust causing medial compartment wear. Stress radiography can quantify laxity, but it's often supplanted by MRI due to its superior soft tissue definition.
MRI is invaluable here. It defines the precise location, proximal, mid-substance, distal, and quality of the MCL injury. It also maps associated damage.
Meniscus, osteochondral, other ligaments. Rubin et al. Showed excellent reliability, though we must be cautious in multi-ligament cases where fluid patterns can obscure definitive tears.
And a fascinating yet unsettling detail from Miller et al.'s work. 45% of patients with isolated MCL tears showed trabecular microfractures, bone bruises.
Which thankfully resolved within a few months. But that tells you the massive forces going through that knee, even in an apparently isolated injury. It speaks to the energy transfer.
Yeah, it really does.
But the most crucial MRI finding, the one that changes an acute, otherwise non-operative treatment plan, is the Steiner analogy.
Okay, what is that?
This is a specific type of injury, a distal avulsion of the MCL where the torn end flips and displaces superficial to the pes tendons.
Like a curtain being pulled across the insertion site.
Precisely. Just like a Steiner lesion in the thumb, where the adductor aponeurosis blocks the ulnar collateral ligament from reducing, this displaced MCL end cannot spontaneously heal back to its bony insertion because the pes tendons intervene.
So that's an immediate indication for open repair.
Immediately. It's a structural impediment to healing, and non-operative management will fail.
That is a critical teaching point. The position of the tear dictates the treatment, not just the grade. Let's move to how we handle the vast majority of the isolated injuries.
As we mentioned, the vast majority of isolated MCL injuries, grades this sex, and even most grade 3s without 0 degree laxity are managed non-operatively. This is thanks to the MCL's robust healing response.
Why is it so robust compared to, say, the ACL?
It boils down to 3 main factors. First, excellent blood supply. Second, its wide surface area allows for significant cross-sectional healing. And third, and most importantly, its extra-articular location.
So it's not bathed in that inhibitory synovial fluid.
Exactly. It allows a fibrous scar to form rapidly. The injury is contained within the fascial envelope, creating a local hematoma and scaffolding for healing.
I recall the nuance from Frank et al. The mid-substance disruptions heal faster than avulsions. Is there a clinical difference in how we approach those different injury types?
Absolutely. Insertion site injuries, the proximal or distal avulsions, have less tissue contact and often heal slower, requiring greater protection in the initial phase. But the overall outcomes remain superb.
And they do. In Delicato et al.'s work on athletes with isolated grade 3 tears showed 95% good or excellent results with conservative management.
Returning to play in about 9 weeks.
9 weeks for a grade 3 tear, that's impressive recovery time. And long-term prognosis is good too.
It is. Lindbergh and Messner confirmed that functional return is excellent, and there is no increased risk of osteoarthritis at 10 years for grades or the second injuries treated non-operatively. The knee maintains its long-term stability.
This just reinforces the need for vigilance. As Holden et al. Noted, 20% of players who failed rehab had unrecognized associated injuries.
Right. If an isolated MCL tear fails to heal by 8 to 10 weeks, you must reevaluate for a missed meniscal tear or ACL injury. The federal rule applies not just acutely, but chronically.
Let's review the standard rehabilitation principles laid out by Ryder et al. For these non-operative cases.
The cornerstones are 1. Stabilization. Use a hinged brace to protect against a second valgus insult and manage pain. It shouldn't lock the knee rigidly, but rather control the arc of motion initially.
And number 2, motion and loading.
Yes. We encourage early motion and weight bearing. This is crucial. Studies support that early controlled stress improves the quality and rate of healing by encouraging the collagen fibers to align along the lines of stress. We don't want long-term immobilization.
And finally, strengthening.
Early quadriceps and hamstring work to optimize dynamic stabilizers. We rely on the muscles to protect the healing ligament.
It's a functional rehabilitation protocol aimed at laying down the strongest possible scar tissue quickly. But let's transition to prophylaxis, the prophylactic knee brace debate.
Oh, the PKB debate, a perpetual topic in sports medicine, especially football.
It certainly is. PKB use is widespread, particularly among collegiate down linemen, the offensive and defensive tackles who are constantly absorbing valgus hits. Does it work?
The lab data says yes.
In surrogate models, Brown and France demonstrated a clear mechanical advantage. Bracing decreases strain on the MCL by 20% to 30%.
And custom-fitted braces offer even improved protection compared to off-the-shelf versions, essentially turning a grade 2 hit into a grade I injury. Biomechanically, the argument is sound.
But translating mechanical models to the unpredictable violence of the football field is difficult.
Very. Sittler et al.'s study at West Point found a decreased incidence of MCL injuries in braced defensive players compared with unbraced controls. Albright et al. Confirmed that linemen, linebackers, and tight ends are the highest risk positions, and bracing significantly decreased injury rates in these groups.
So the protection is real, but there's always a trade-off. Performance limitation.
That's the sticking point. Albright noted that linemen are compliant, but linebackers and especially tight ends are often resistant. Green et al. Showed that some braces decrease speed and agility, which can be unacceptable for skill positions.
You can't tell a wide receiver to lose a tenth of a second on their 40-yard dash for MCL protection.
You really can't. And Steve et al. Added a physiological layer to the debate, suggesting that braces, due to the circumferential compression, can increase intramuscular pressures, potentially leading to earlier muscle fatigue.
So you might be protecting the ligament, but tiring out the dynamic stabilizers sooner.
Exactly. The clinical decision matrix is therefore position-specific. For the down linemen, the risk of injury is high, the impact is predictable, and their athleticism is secondary to power and blocking. Protection outweighs the subtle performance decrease.
But for skill positions, the risk-reward calculation flips.
It does. It's a nuanced discussion we must have with every athlete, factoring in their history, position, and competition level.
All right, we've handled the isolated tear. Now, the complexity increases significantly. The combined injury, most commonly an ACL tear, with a grade 2 or grade 3 MCL tear.
This is the true dilemma. As we established, the ACL acts as a secondary stabilizer to valgus stress.
Oh!
Aller's basic science work showed that the loss of a functional ACL severely diminishes the capacity of the MCL to heal robustly with non-operative treatment.
And conversely, a stable medial side is crucial for the success of a reconstructed ACL graft.
It is, and historically, this led to significant debate. Zaffanini et al. Initially found that treating the ACL alone might lead to greater immediate postoperative valgus laxity, raising fears that this residual medial laxity would prematurely fail the ACL graft.
So the initial response was often to repair everything acutely and simultaneously.
And that approach was largely abandoned due to a major complication: arthrofibrosis, severe stiffness.
Which is often more disabling than the instability itself.
Way more disabling. Noyes and Barbara Weston highlighted that early, simultaneous repair or reconstruction of multiple structures, especially the medial side, led to unacceptable rates of postoperative stiffness.
So the current standard of care, the shifting consensus, is that the literature leans heavily toward a staged approach.
Correct. Non-operative treatment of the MCL component if the ACL is reconstructed acutely after the patient has regained full pain-free motion.
And the rationale is twofold.
Yes. First, the healing potential of the MCL remains high because it's extra-articular. Second, studies show that residual laxity tends to be asymptomatic. Shelburne and Porter demonstrated that the outcomes for ACL reconstruction alone in this combined injury pattern were similar to isolated ACL tears.
The residual medial instability was functional but not clinically relevant in most patients.
Right. And the prospective randomized trial by Helenen et al. Really cemented this protocol. They compared early ACL reconstruction plus MCL repair versus ACL reconstruction only. The key finding was no difference in objective outcomes at the 2-year mark.
But, and this is why we choose the ACL-only route, the ACL-only group regained motion and quadriceps strength faster.
Faster rehab, lower morbidity, and equivalent long-term stability. The risk of simultaneous medial repair arthrofibrosis outweighs the benefit of slightly tighter valgus stability in the acute phase, especially since the MCL usually heals well on its own once the knee is protected.
And this is the standard of care for adults and, as Anchor et al. Showed, for pediatric patients as well.
It is.
But of course, we need to know the exceptions. When do we violate that standard and perform a simultaneous reconstruction?
You must intervene surgically on the MCL when the patient exhibits persistent valgus laxity at the time of ACL reconstruction, particularly if that laxity is present in full extension.
These are the red flag criteria.
Yes. We are talking about a patient who has been braced for 4-6 weeks, has good range of motion, but still has a clear opening at 0 degrees.
So if the deep anchors, the POL, have failed to heal, then the stability will not return, and the ACL graft will definitely be subject to increased valgus strain.
Correct. The other exception is the chronic ACL tear with residual valgus instability. If the patient presents months or years after the initial injury with a lax ACL and a lax MCL, Zhang et al. Showed that you will achieve superior stability by performing a simultaneous MCL reconstruction along with the delayed ACL reconstruction.
Chronic instability often requires mechanical reconstruction.
Exactly.
Finally, we have the real disaster scenario, multi-ligament injuries and knee dislocations.
Oh, these are the cases that ruin your weekend. If you have a true knee dislocation, a KD3 or worse, we have to be extremely worried about neurovascular status and subsequent stiffness.
So Finelli and Edson often recommended a staged approach for cruciate reconstruction to allow soft tissue swelling to subside and motion to be regained, primarily to avoid arthrofibrosis.
They did, but the medial side generally requires repair or reconstruction in these catastrophic injuries, right?
It does. For grade 3 medial instability in a knee dislocation, you often need robust reconstruction. Standard recommended using allograft or autograft reconstruction for medial instability in knee dislocations across the board.
The debate shifts from if to when immediate repair risks stiffness, but delayed repair risks progressive instability.
Right.
Many specialists prefer stabilizing the dislocated knee first, waiting a couple of weeks to regain motion, and then reconstructing the cruciates, addressing the medial side if it remains significantly unstable at that later date.
Okay, if non-operative management fails, or if we are facing a chronic or acute persistent instability, we move to reconstruction.
And modern techniques are built on the principles of anatomic replacement, moving far beyond the simple non-anatomic procedures like the original Bosworth procedure.
The evolution has been key. The critical technical distinction, which we must hammer home, is the tibial fixation point.
It is. The SMCL graft must be secured within the native fiber footprint of the SMCL, that's 4 to 6 centimeter distal to the joint line. It must not be secured at the attachments of the pes anserine tendons, which sit much more anteriorly.
And if you place that graft too anteriorly, what happens?
You immediately risk limiting knee flexion. The graft becomes taut too early in the arc of motion, leading to a flexion contracture or stiffness. We are trying to replicate the oblique, slightly posterior trajectory of the SMCL, not the anterior pull of the pes.
It's an anatomical subtlety that determines surgical success or failure.
It really is.
Let's detail the preferred technique from our sources. The anatomic single bundle, or ASB, technique for the SMCL, combined with a meticulous pants-over vest imbrication for the POL and the PMC.
We prefer a doubled ST autograft, or sometimes a long allograft for revisions. The approach requires careful dissection. After harvest, we make a longitudinal capsular incision posterior to the SMCL. The goal is twofold. Visualize the damaged POL and provide access to tighten the BEEP structures.
The pants-over vest technique is the repair for the deep layer. We are layering the capsule to tighten the posterior corner.
Right. We use several heavy, non-absorbable sutures for this imbrication. This is not just a cosmetic stitch. It restores the static tension to the POL central arm. It's then reinforced with a running suture,
And here is the most critical technical detail of this entire procedure.
the one that guarantees success or catastrophic failure regarding stiffness. You must tie these imbrication sutures with the knee flexed no more than 10 to 15 degrees.
Why that precise range?
If you tie the sutures in full extension at 0 degrees, you overtension the posterior capsule, practically guaranteeing a severe limiting postoperative flexion contracture. That small 10 to 15 degree window allows for just enough soft tissue slack to permit full free extension post-op, while ensuring that the deep structures are taut enough to restrain valgus and internal rotation in extension.
It's the difference between a mobile knee and 6 months of grueling, failed physical therapy.
No question.
Now, for the ASB reconstruction itself using the graft, we are going back to the Laprade coordinates.
Correct. We create the femoral tunnel in its anatomic spot, the 3.2 millimeter proximal, 4.8 millimeter posterior mark relative to the medial epicondyle. This establishes the correct kinematic trajectory. We then use the prepared graft to locate the tibial tunnel,
The tibial site needs to be 4 to 6 centimeter distal to the joint line.
ensuring at least 25 millimeters of usable graft length inside the tunnel for fixation. We drill the blind tibial tunnel first, 25 millimeter deep. The femoral tunnel is drilled to, but not through, the lateral cortex.
And you can use fluoroscopy to confirm placement.
You can, aligning the femoral tunnel with the intersection of the posterior cortical line and the Blumenstadt line, as confirmed by Hartshorn and Widdix. We are surgical cartographers at this point.
I like that. Now, fixation.
We secure the inferior limb of the graft to the tibia. We typically use an 8 by 23 millimeter peak screw. We prefer the biotenodesis technique, securing the suture over the top of the screw head for backup and added compression. The 8 millimeter diameter provides robust fixation for the distal hamstring graft.
And then, the moment of tensioning the femoral side, the final step that sets the tone for the knee's stability.
Absolutely crucial. The femoral graft is passed into the tunnel and then tensioned in the position that best mimics the native ligament's function, with the knee in 30 degrees of flexion and applying varus stress.
And you fix it with a slightly larger 9 by 23 millimeter peak screw.
We do.
Why the jump from 8 millimeter to 9 millimeter peak screws?
Often the femoral bone quality is better, and the slightly larger diameter provides maximum pull-out strength in the cortical bone. Furthermore, tensioning at 30 degrees of flexion isolates the SMCL, avoiding the stiffness caused by tensioning the POL in full extension. Applying varus stress ensures we eliminate all remaining medial laxity at that critical flexion angle.
And the peak screws themselves. They are essential for strong interference fixation, but without the scatter artifact of metal, allowing for clean post-op MRI surveillance if needed.
A huge benefit for follow-up. After fixation, we reinforce the femoral end by suturing the graft sleeve to the surrounding soft tissue, and the tibial end is sewn to the residual SMCL starting about 1 centimeter below the joint line. The goal is a seamless blend with the native anatomy.
Finally, let's discuss the post-operative rehabilitation protocol that protects this complex reconstruction.
The first 2 weeks are mandatory protection. Touchdown weight bearing only, in a long leg brace locked in full extension. We want 0 valgus stress on that repair.
For the next 4 weeks, up to 6 weeks total.
Progression to full range of motion and advancing weight bearing is allowed, but the patient must remain braced in extension when ambulating. We control motion, but restrict stress.
And only after 6 weeks is the brace discontinued.
Right. Once the initial biological healing has started. Return to cutting and sport activities is dictated by the healing of other associated injuries, like the ACL, but the medial side needs that dedicated, protected 6-week period.
That was a comprehensive, high-yield discussion, moving from the classic anatomy to the latest technical details using peak screws. The takeaway remains clear. The medial knee relies on the Warren and Marshall 3-layer security system. The SMCL, layer 2, is the primary valgus restraint, and the DMCL-PL, layer 3, provides crucial stability in extension and rotation.
And this complexity drives our treatment algorithm. We favor non-operative management for isolated MCL injuries because of the robust extra-articular healing.
But we must have vigilance.
Always. The 0 and 30-degree stress exam is mandatory, and increased laxity and full extension suggests associated injury. The FETO 80% rule is always our guide to combined instability.
In the common ACL-MCL combination, the current evidence dictates prioritizing the ACL reconstruction after motion is regained, letting the MCL heal non-operatively.
Right. We only intervene surgically on the MCL component if persistent critical valgus laxity, particularly in extension, remains after the acute healing period.
And if we operate, precision is everything. Anatomic tunnel placement, using the 3.2 and 4.8 coordinates, tensioning the graft at the functional position of 30 degrees of flexion with varus stress.
And remembering the critical 10 to 15 degree flexion window when tying the POL imbrication to prevent stiffness.
Here's a final provocative thought for you to explore as you synthesize this material. We relied heavily on Wigdich's concept of load sharing and the intrinsic dependence of the medial structures on the ACL for secondary stability. Our current surgical approach, the ASB, uses static anchors, peak screws tension only once at 30 degrees of flexion. Considering the constant shifting of tension demonstrated by Robinson et al. Throughout the arc of motion, how might future reconstruction techniques move beyond these static anchors to functionally replicate the dynamic reciprocal load sharing of these ligaments throughout the entire range of motion?
That's the million-dollar question.
Could we ever build a synthetic structure that truly mirrors the biomechanical flexibility of the native system? Or will the complexity of the tri-layered PNC always limit our ability to achieve true dynamic anatomical replication?
It challenges the assumption that simple fixed tensioning can solve a multi-plane, multi-degree problem. It's the next frontier in ligamentous surgery.
Indeed. Something to mull over as you close your notes. Thank you for joining us on this deep dive into the medial knee.
We look forward to our next discussion.